It's a real privilege and honor to be given the opportunity to speak at this forum, and I'm deeply thankful to my good friend Dr. Ashish Singh for the kind invitation, and I must congratulate him for a wonderfully organized meeting. I have no disclosures to make, and therefore I would like to proceed with my talk. Now, revision total hip arthroplasty is on the increase, and some of the reasons for that is that it's being used in wider and wider situations and in younger and younger patients. About 18% of total joint surgeries performed worldwide are actually revision hips, and the majority are still due to infection, but aseptic revisions form a significant percentage of these surgeries, and particularly on the acetabular side. This is from Paprosky's paper in 2003. Now, there are various factors which influence survivorship in total hip arthroplasty, and these include patient surgery factors and quite importantly implant factors. And if we look at the implant issues, then the concern here is the problem of wear and aseptic loosening. Now, this is a bugbear which dogged total hip arthroplasty ever since its inception, and it was wrongly believed to be due to bone cement, and in fact it was erroneously called cement disease. And it took some years to realize that the problem was actually with the plastic, and this plastic caused particle-induced inflammatory response in the host and caused bone loosening. And therefore, the goal today to increase survivorship in total hip arthroplasty is to improve the plastic, and we have moved fairly reasonably in that direction, which we shall see in some detail. This is a picture which shows the typically osteolytic zones around the acetabulum and the femoral shaft, which presage the onset of loosening. Survivorship, the single most limiting factor is actually the bearing surface, which is responsible for wear. If you look at the wear rates of various bearing surfaces, then this is what it looks like. But what is very remarkable from this list is the difference the highly cross-linked polyethylene has made to wear rates. This is the conventional polyethylene, which was used before 1995, and it showed a very, very high volumetric wear, which resulted in a high incidence of particle-induced osteolysis. And this was actually one of the game changers in the history of arthroplasty, was the formation of the highly cross-linked polyethylene, 10 megarads, which produced cross linkages between the polymer chains. So there were two other processes which were involved. The one was a remelting and the other is annealing. Each had its advantages and disadvantages. So a bit of chemistry here. If you irradiate polyethylene in the presence of oxygen, then it breaks up the chains, and this poly is very short-lived. But when you do it in the presence of vacuum or hydrogen, then there is a linkage which happens, and this is a disulfide link, and it greatly increases the resistance to wear. However, this highly cross-linked polyethylene is not without its problems. It's quite brittle. As you can see, it's got very, very low wear, but it's quite brittle and is prone to fracture more than the conventional polyethylene. Metal-on-metal articulation was once held a lot of promise, but ever since this happened, the massive pseudotumors, it is today out of the window. Ceramics have also contributed to reducing wear, and we've had various generations of ceramics, and what is in use today is the third generation Biolox Delta, and I think from lack of time really we can't go into much more detail than that, but this graph shows quite how remarkable the low wear rate is with ceramics. Problems with ceramics: it's prone to fracture. It has improved a lot, however, with the third generation ceramics, but even so there's a problem. And the other problem is that it requires very, very precise surgical technique. Otherwise you get what is called the impingement from the edge of the ceramic, and this can cause metal transfer, runaway wear, and squeaking and other complications. So if you are to look at a brief algorithm, then in the young patient, ceramic on ceramic; in the middle-aged patient, ceramic on highly cross-linked poly; and in the elderly patient, the metal on poly can still be used. Patients with aseptic loosening, they usually present with a startup pain, which may be in the groin or thigh, depending on whether it's acetabular or femoral loosening, and it can sometimes be referred to the knee. They may come with a Trendelenburg gait because of shortening and subsistence. Usually this stem goes into retroversion and can actually dislocate, and the patient can present with significant gait disturbance. The radiologic signs: in the cemented, you will see the clear zone of osteolysis all around the gruen zones in the stem and in the retro acetabular area. And there may be migration of components in the non-cemented stems. In the unstable implant, you will see lucencies and a migration of implants. Sometimes you will see a pedestal formation in the femoral stem. Complications actually may lead to pathological fracture, inequality, or sometimes the implant breakage. An example here of a pathological fracture happening due to osteolysis, a pelvic discontinuity because of retroacetabular osteolysis. In these cases, if you are to treat them, then there are various acetabular augmentation options which are available. This is the impaction bone grafting with a non-cemented socket, which can be used to reconstruct defects. This is an example of such technique having been used. If the patient is osteoporotic, particularly in rheumatoids, then you may need to go for the cemented option. An example here where you may need to make up rim defects in the aorta type 2, for instance, with tantalum meshes, and then they work reasonably well as well. An example here of a cemented reconstruction in a bone defect. Structural grafting, especially when there is a rim defect. An example here where this is of course a primary situation where the femoral head was used. In the revision, you can use an allograft, a femoral head allograft. Jumbo cups are also useful in treating loosening in the acetabulum with bone defects. The oblong cup is sometimes useful, especially if you have a superolateral defect. Bone grafting and cages are generally on the decline, but then in certain instances you may still need to use it, as in this example. Yet another example of a complex acetabular reconstruction with a cage. The ring, okay, I'll just take another. The rings may be used as well. Example here, treated with an octopus ring. Another severe acetabular defect with an octopus ring. Strategies for femoral defects is the modular femoral stems are useful, and the literature says that they are very, very encouraging clinical outcomes. An example here where the SROM was used. Another example of osteolysis with loosening managed with SROM. In the severe Paprosky type 3 and 4 defects also the SROM stem is useful. Some examples: fully coated stems, especially if you want a good distal fit. Another example here: distally fixed stems if the metaphysis is too far gone and you get absolutely no hold there, then may need a purely distal fixed stem. The problem is of proximal stress shielding. Impaction bone grafting for femoral stems is also a useful technique if you wish to go the cemented way. And in summary, symptoms of component loosening can be subtle or apparent, clinical symptoms, and usually radiology is sufficient to clinch a diagnosis. Delay in revision can lead to disastrous results. Highly cross-linked polyethylene has diminished the incidence of particle-induced osteolysis, and the surgical management involves very careful implant selection, use of modularity.